Hello. Hello. Hello.
Good afternoon, sir.
Good afternoon.
Hope I'm audible to you, sir.
Hello.
I hope I'm audible, sir.
Audible. Can you hear me? Am I audible to you? Hello.
Audio.
Hello. Can you hear me? You can hear
Hello,
me.
good afternoon, sir.
Hello. Good afternoon. Good afternoon. Can you hear me? Am I audible? Hello. Am I audible to you? Hello. Hello. Am I audible? Hello. 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 Am I audible? Hello. Hello. Hello.
Good morning, sir.
Good evening. Good afternoon. Can you hear me?
ഇപ്പം കേൾക്കാം.
ഇപ്പൊ കേൾക്കാം. Yeah, there was some problem അല്ലേ? Okay.
How are you?
I'm fine. Thank you.
അതിന് ഷെയർ ചെയ്യാൻ
Shall I share your time?
ഒരു തുടങ്ങിയിട്ട് ഇട്ടാൽ മതി സാറിന് പ്രശ്നമില്ലല്ലോ.
ഓക്കെ, ഇല്ല കുഴപ്പമില്ല.
2 മണിയായോ?
2 മണി ആയി തുടങ്ങി. ആയി 2 മണിയായി.
Okay. So, good afternoon and welcome to the Masterclass series of PK Institute. This is the 24th Masterclass, I think. And today we have got a very important topic. Beyond any specialty, and patients will come irrespective of specialty with complaints of anemia, and the manifestations may be varying. Somebody with a cardiac problem, can you hear, sir?
I can hear.
And the presentation may be with chest pain, but actually the underlying problem is anemia. And so today's topic is a clinical approach to anemia. And to chair the session and to introduce the speaker, I request Professor Vinod Raghavan, Professor and Head of the Department of Medicine, to introduce the topic and the speaker and continue with the program. Over to sir.
Good afternoon, sir. Good afternoon to everybody. Respected Director, sir, Dr. R.C. Krishna Kumar, sir. Respected Principal, sir, Dr. M.A. Andrews, sir. Senior colleagues and friends, it is our privilege today to welcome Dr. PK Sasidharan, MD, FICP, FRCP, former professor and HOD of the Department of Medicine and Hematology at Calicut Medical College, and now presently senior consultant in PVS and Aster MIMS Hospital in Kozhikode. Professor Sasidharan, sir, has been an eminent teacher and is one of the senior-most hematologists in our country, and has been treating hematological conditions since the early days when hematology was still a nascent science in our country, before the advent of modern-day molecular and genetic diagnostic tests. He will be talking to us today about the clinical approach to anemia, which is the commonest hematological problem as it presents to the generalist, be they physicians, pediatricians, surgeons, or gynecologists. Because despite all the advances in molecular and diagnostic tests, the accurate evaluation of a patient still depends on a clinical approach, like in all of medicine. Over to you, sir.
Thank you. At the outset, let me thank Dr. Andrews and the HOD Medicine and all the people who are attending this session. Shall I share the screen?
Yes, sir. Yes, sir, please do.
Yeah. Can you see now?
You can see slides, sir. Individual slide. Yes, sir. You can see now. Sir.
Okay. So I will be just focusing on purely practical points related to evaluation of patients with anemia. This will be the major areas we will be covering: an overview of anemias with a focus on iron deficiency, betel deficiency, and along with that, usefulness of the automated hemogram also will discuss. Basically, there are 4 major types of anemia: decreased production, blood loss, which can be acute or chronic, hemolysis, and anemia of chronic inflammation, chronic infection, or due to chronic diseases like CKD, liver disease. The decreased production, the most important, are due to deficiency of nutritional deficiency of iron, folic acid, B12, and also hypothyroidism. And among the nutritional deficiency, protein intake, decreased protein intake is most often overlooked. Many patients who are referred to as refractory anemia to me are actually having decreased protein intake or having butyl folic acid deficiency besides iron deficiency. Sometimes decreased production, especially in a referral center, can be due to infiltrative disorders of the marrow, aplasia or hyperplasia, or rarely myelodysplastic syndromes, which are categorized under the bone marrow failure group. The causes of iron deficiency itself are multifactorial. It may be decreased dietary intake or impaired absorption due to multiple factors again, or increased iron requirement as in infancy, growing children, or pregnancy, lactation, or sometimes due to increased iron loss as in hemorrhoids or menorrhagia, or even chronic low-grade intravascular hemolysis. Increased iron loss, you have numerous causes. All these we need to elicit when a patient comes with unexplained anemia. It may be hemorrhoids or chronic NSAID intake, especially even the low-dose aspirin, or peptic ulcer, hookworm infestation. Even hiatus hernia can be a cause of continued low-grade blood loss. Neoplasms, ulcerative colitis. Sometimes the site is unknown. The GI site may be unknown. It is very difficult to localize sometimes. Or it may be menorrhagia, repeated blood donation, hemoglobinuria, especially the chronic intravascular hemolysis due to prosthetic valve, mechanical hemolysis, or hereditary hemorrhagic telangiectasia with blood loss from multiple sites, especially GI. Disorders of hemostasis or CKD, and sometimes the causes are not very clear after initial evaluation. These are issues of nutritional deficiency, butyl folic acid and protein deficiency because of wrong dietary practices and or basically lack of balanced diet, and other causes of deficiency like malabsorption or autoimmune mechanisms for butyl deficiency. Infiltrative diseases can be leukemias, lymphomas, myeloma, myeloproliferative disorders like myelofibrosis, or sometimes it is chronic granulomatous diseases like tuberculosis or CALAS or metastasis can be the cause for bone marrow infiltration. The anemia due to blood loss can be presenting as an acute blood loss, in which case it is dominated by hypovolemic symptoms. Anemia it may not be the predominant symptom with hypotension and fatigue and syncope, postural hypotension. But the chronic blood loss presents with iron deficiency anemia with hypochromic microcytic anemia. And the chronic blood loss also may be obvious or occult. And we need to look for occult blood loss as well. The blood hemolytic disorders can be hereditary, as in hereditary spherocytosis, sickle cell disease, thalassemia. Though it is considered hemolytic, it is more often dyserythropoietic, or G6PD deficiency. Sometimes infective or toxic factors like malaria infection, clostridial infection, copper, as in Wilson's disease, or copper sulfate poisoning. Certain drugs may be responsible for the hemolysis like methyl dopa. Immune mediated can be autoimmune or hemolytic disease. In newborns, it is hemolytic disease or newborn. PNH is a complement mediated hemolysis. It's an acquired disorder. Mechanical hemolysis can be occurring in microangiopathic hemolysis of multiple etiology and prosthetic valves. Coming to the approach, we must be aware of the causes of anemia and their clinical presentations. And only we can look for it. A detailed history, including a detailed artery history and very meticulously executed physical examination, can give the clue to the diagnosis in majority. And then after making up our mind regarding what are the possibilities, then if you look at the automated hemogram, you get tremendous information regarding the etiology after a clinical diagnosis. Without a clinical diagnosis, they will not help. The complete blood count helps only if you have clinical diagnosis. So the patient with anemia may be presenting because of anemic symptoms, which depends on the severity of anemia and the rapidity of development of anemia, and at that point of time, the status of the cardiovascular and respiratory system. If the cardiovascular and respiratory system are compromised, the symptoms may be dominated by their symptoms. Sometimes there may be symptoms due to the cause of anemia, like that of iron deficiency, pica, neuropsychiatric manifestations, or beetle deficiency causing numbness, tingling numbness. Or the CS stomach may be there, patient may be having early satiety, melena, or symptoms due to the comorbidities like ischemic heart disease, transient ischemic attack. Very often, the pallor is detected by a relative or a doctor when the patient consults for one of the vague complaints. These days, because of the inadequate application of clinical skill and doctor shopping, most of the anemias are picked up by the hemogram. With a low, they come with a low hemoglobin, no diagnosis. These are some of the commonest symptoms. Fatigue is by far the commonest symptom in any anemic patient. It may be due to anemia itself or due to the causes of anemia like chronic kidney disease, hypothyroidism, or the hypotension, which may be the cause of anemia. Breathlessness may be there due to severe anemia itself, but often it is due to aggravation of symptoms due to underlying respiratory or cardiovascular illnesses. Dizziness, which can be exertional syncope or postural syncope in case of acute blood loss. Sometimes they come with refractory headache or refractory migraine. This is very common with iron deficiency anemia. Like Dr. Andrews said in the introduction, some of them may be coming because of angina. Some may be coming because of transient ischemic attack involving any vascular territory. Some of them may be coming because of the angina or transient ischemic attack, and sometimes very often they even get into wrong consultations also. If you are careful, we will get symptoms due to iron deficiency like the pica or neuropsychiatric manifestations in children. Tingling, pins and needles and numbness may be elicited in suspected betal and folic acid deficiency. The patient might casually mention it. Unless we are aware of it, we may not elicit it. Anorexia may be due to the atrophic gastritis or betal deficiency, but it can also be due to the coexisting peptic ulcer disease or even a CS stomach. Dyspepsia is very common in anemic patients due to anemia itself, but it can be due to the underlying acid peptic disorders. Amenorrhea can be seen in severe anemia of any etiology. Some of them, especially due to betal folic acid deficiency, may be even having infertility. Some patients, if they have compromised cardiovascular system, may be presenting with aggravation of cardiac failure. And the focus may be on the cardiac failure, but the real genuine cause may be the anemia. If the cardiovascular function or the contractility of the myocardium is very good, because of high volume cardiac output, they may come with ringing in the ears or palpitation or exertion. But this will not occur when the myocardium contractility is poor due to underlying ischemic heart disease or some other reason. Sometimes the systolic murmurs may be picked up and the cardiovascular valvular abnormality may be suspected. So when you get an anemic patient, whatever way the patient comes to you, or if it is diagnosed by a hemogram, always look for multiple causes. In fact, all anemias are multifactorial, and dietary deficiencies itself can be multifactorial. Iron, betal, and folic acid deficiency often coexist. And to add to that, sometimes hypothyroidism also. And look for a blood loss from any site, including commonly are menorrhagia and hemorrhoids, or bleeding from peptic ulcer or hiatus hernia. Early satiety can be indicative of atrophic gastritis or betal deficiency, or sometimes it may be rarely a carcinoma stomach. Jaundice, especially if it is recurrent, indicates a hemolytic disorder. Sometimes you get chronic active hepatitis and anemia due to multiple reasons. There also you may get a history of recurrent jaundice. Color of urine is useful because a patient with jaundice, anemia, normal color indicates hemolysis. If it is yellow, indicates hepatocellular damage. Anemia and hepatocellular damage or color-colored urine can occur in intravascular hemolysis. Febrile patient with anemia, one should consider malaria, infected endocarditis, rheumatic fever, tuberculosis, or hematological malignancy. Recently, we had a patient with brucellosis who had undiagnosed anemia and splenomegaly. It turned out to be brucellosis. Weight loss also
Hello.
should, hello, any problem?
സുഖമില്ലല്ലോ അടുത്ത ആഴ്ചയിൽ വിളിച്ചിട്ട് വരും
Hello,
ആരാ വിളിക്കുന്നത്
weight
അടുത്ത
loss may,
ആഴ്ചയിലേ ഒരാഴ്ച കഴിഞ്ഞിട്ടൊന്ന് വിളിച്ചിട്ട് വന്നാൽ മതി ശരി
weight loss may be due to chronic infection or a neoplastic disorder underlying, like tuberculosis can present with anemia due to multiple reasons. Weight gain, if it is there, could suggest hypothyroidism. Diarrhea might suggest a malabsorption due to tuberculosis, or chronic blood loss may be there in that background, especially if there is a colitis, like ulcerative colitis, which may be the cause for chronic blood loss. Dietary history has to be meticulous. The quality in great detail we need to explore, because most patients with refractory nutritional anemias do not get adequate iron, betel or folic acid. Even protein intake is missing in them. If they're strict vegetarian, almost 100% they have betel deficiency. That has to be elicited. And the adequacy and nature of protein intake is also equally important. Whether the meat only contains iron, but at least protein should be there for hemoglobin synthesis. And vegetables and fruits are important for getting folic acid. So unless we take a proper dietary history, we are going to miss most of the nutritional anemias and the causes for it. Color-colored urine, as I mentioned, can indicate intravascular hemolysis. Arthritis, arthralgia, and bone pain in an anemic patient can suggest SLE, leukemia, myeloma, or sickle cell disease if it is a patient of tribal origin. Cold intolerance and constipation can suggest hypothyroidism. Always look for symptoms and signs of chronic kidney disease and chronic liver disease. Drug intake is very important. Drug history is extremely important, including NSAID. But these days, more importantly, betel and iron deficiency especially, are often due to prolonged PK intake. The pantoprazole is a regular treatment drug in most of the patients. And metformin also will interfere with the betel absorption. Methyl dopa can produce hemolysis. Phenytoin can produce hemolysis and folic acid deficiency. Carbamazepine can produce bone marrow aplasia. Chloramphenicol is known to produce it. Methotrexate, folic acid can produce folic acid deficiency. Always inquire about these drugs. Nitrous oxide, prolonged nitrous oxide anesthesia can produce an acute betel deficiency. We had one patient who had a prolonged surgery following electrocution and multiple amputations, and following which the patient went into pancytopenia and septicemia. The awareness regarding nitrous oxide causing betel deficiency was the clue to diagnosis. Very often it is indigenous medicines these days. There are several drugs which contain copper, some drugs for diabetes, some tablets. I had one patient from Thrissur who was brought up with an undiagnosed hemolytic anemia. The medicine that he took for diabetes contained copper. And copper-induced hemolysis can occur due to poisoning also, copper sulfate. Always elicit, in females, always elicit the repeated pregnancies. But each pregnancy, some 600 milligram of iron is lost. And before that is replenished, another pregnancy happens. They will definitely have multiple deficiencies. Gastrointestinal surgery like gastrectomy, bypass surgery, gastric bypass, ileal resection, all this can lead to anemia by multiple mechanisms. Blind loops, bacterial overgrowth can also be there. Ileocecal tuberculosis can predispose to not only blood loss, betel malabsorption. Ingestion of corrosives can decrease intrinsic factor secretion from the stomach. Alcoholism is associated with multiple reasons for anemia, including blood loss, folic acid deficiency, and liver disease causing anemia. So always explore the chance of developing chronic liver disease in anemic patients, because liver disease can cause anemia by multiple mechanisms. This patient, for example, had a refractory anemia with features of iron deficiency, betel and folic acid deficiency. What happened was he had repeated surgeries for a congenital malformation of the intestine, after which he had refractory anemia. In fact, he had all the deficiencies, malabsorption of betel including, and decreased intake, and he had to be given a proper diet and replacement of iron parenterally, iron and betel parenterally initially to correct the anemia. And family history and background of the patient and occupation is very important. If there is a family history of anemia, it can suggest thalassemia trait or other hemolytic disorders like hereditary spherocytosis, or ask for family history, jaundice, and splenectomy in case of hereditary spherocytosis. A tribal origin can suggest sickle cell disease, and occupational exposure to lead is very important. And in agricultural areas, sometimes acute severe anemia with hemolysis and hepatocellular damage can be due to a copper sulfate ingestion. The physical findings will also suggest the causes. The patient is extremely emaciated with anemia, think of a chronic infection, GI malignancy, and malnutrition related problems. Tuberculosis may be very often coexisting. If there is glossaritis, cheilitis, ankylostomatitis, and other nutritional deficiencies, that will give the clue to the anemia. But one nutritional deficiency always means multiple nutritional deficiencies. Always look carefully for nail changes of iron deficiency. It need not be the koilonychia. Initially, it may be just flattening, longitudinal ridging, and then lastly only the koilonychia appears. Always carefully look for skin and hair changes of B12 deficiency. The premature graying of hair and hyperpigmentation of the skin. Carefully look for skin changes of chronic liver disease and chronic kidney disease. Look for purpura, ecchymosis, gum bleeds, lymphadenopathy, and gum hypertrophy to suggest hematological malignancies. And in case you suspect hematological malignancies, always look for sternal tenderness. The nutritional status can suggest, for example, that the patient looks malnourished, it indicates nutritional deficiency anemia. But apparently normal-looking person with anemia alone as the problem, consider hemolytic disorders, B12 deficiency, GI blood loss, or myelodysplastic syndrome, rarely aplastic anemia. The nail and mucosal changes of iron deficiency were carefully looked for, as I mentioned before. Look for features of hypothyroidism. Look for jaundice, Lemonella jaundice if the patient has hemolytic jaundice. But if there are gallstones, you may even get obstructive jaundice. Bradycardia might suggest that patient could be having hypothyroidism. Clubbing in an anemic patient could suggest underlying cirrhosis. If the patient is febrile, infective endocarditis as well. Edema suggests CCF, but it could be hypothyroidism or chronic kidney disease with anemia and edema. Non-healing ulcers can occur with hereditary spherocytosis, sickle cell disease, and vasculitic disorders with anemia. Always look for them. CVS, look for valvular lesions. That may be the clue to an underlying infective endocarditis or even a mechanical hemolysis. Liver span and consistency to suggest liver FAM hepatomegaly indicates chronic liver disease, and that may be related to the anemia. Look for epigastric lump in case of CS stomach, a right iliac fossa lump sometimes in ileocecal tuberculosis. Splenomegaly, if you get an anemic patient, definitely supports hemolytic disorders or subacute bacterial endocarditis. If a patient is febrile or otherwise, sometimes in vivax malaria fever may not be there when the patient comes. Hematological malignancies like CML or lymphoma, splenic lymphomas with hypersplenism, myelofibrosis. Hypersplenism should be entertained if the cause of splenomegaly is not obvious. Or rarely it could be tuberculosis, brucellosis, or HLH these days. Recently, the patient which I mentioned regarding brucellosis had a moderate splenomegaly, severe anemia, and it was actually brucellosis with HLH producing moderate splenomegaly and pancytopenia. So ultimately, by good history, proper clinical evaluation, we would have arrived at a clinical diagnosis with the possible causes. And with that, we look at the hemogram. We get most of the diagnosis we get from these two steps. And some specific tests are needed only in selected cases. This patient had she had gone to an ENT with a severe migraine headache, and pallor was detected. And then once pallor was detected, the patient was referred for evaluation. You can see the ankylostomatitis. The pallor is not obvious sometimes. Iron deficiency need not always manifest with pallor. Only when it is severe, the pallor appears. This is enough, and the pica may be there even before pallor appears. Such gross nail changes are rare unless the nutritional deficiencies are severe. Anyway, we need to look for even subtle changes like flattening, longitudinal ridging of brittleness of the nails. The edges may be serrated and brittle. This may be obvious sometimes. The flat nails, the koilonychia comes much later. These are gross cholecystinuria. It was a 30-year-old mother of 3 children, poor diet, and there was no blood loss, but the eosinophilia in the blood and hookworm over were demonstrated in the stool. The same patient, you can see the cheilitis, angular stomatitis, which are very obvious findings of iron deficiency. This patient had, as I mentioned, look for multiple causes even for iron deficiency. This patient had typical iron deficiency with glossitis, cheilitis, angular stomatitis, but there was menorrhagia also, which again was due to hypothyroidism and chronic ITP, and in addition fibroid uterus. So for each condition, there are multiple causes. Nutritional deficiencies may be multiple. Iron deficiency itself may be due to multiple causes. This patient had constipation, dyspepsia, and hemorrhoids. It was hypothyroidism in the background with bleeding from the hemorrhoids causing iron deficiency anemia. In addition, thyroxine will contribute to the anemia because thyroxine is required for hematopoiesis. This patient had the same problem, hypothyroidism and B12 and folic acid deficiency in addition. You can see the knuckle pigmentation. So anemia is always multifactorial, even if it is nutritional. Don't be so happy with the diagnosis of iron deficiency, and the patient is not going to improve with the correction of iron therapy alone. This patient had a chronic duodenal ulcer and poor dietary intake. You can see the smooth shaven tongue, and this kind of glossitis usually indicates B12 deficiency as well. And we used to say that iron deficiency can be diagnosed easily from peripheral smear. These days, it is not needed. This is a typical peripheral smear showing anisopoikilocytosis, but the RDW is enough nowadays. It contradicts anisocytosis. It's easy to diagnose anisocytosis by a high RDW. In fact, we don't have to get a peripheral smear to diagnose iron deficiency these days. So therefore, to diagnose iron deficiency, we need a complete hemogram with low MCV, raised RDW, and thrombocytosis. Peripheral blood smear is not needed these days, and other investigations to find the cause of iron deficiency may be needed, like where is the bleeding from? Maybe is it a duodenal ulcer or a carcinoma stomach? We may have to investigate that for that. But low MCV can also be seen in rare conditions like sideroblastic anemia, thalassemia trait, and anemia of chronic disease. But in thalassemia, the RDW is not high. The hemogram is extremely useful in diagnosing anemia these days. This is a normal hemogram showing we need to focus on hemoglobin, hematocrit, total count, differential count, MCV, and RDW. These are enough to categorize the anemia. You can see that here the hematocrit is normal, 46, MCV is normal, 82, platelet count is normal, RDW is 12.4. When the RDW is more than 14, suspect iron deficiency. When MCV is less than 80, suspect iron deficiency. When there is thrombocytosis, suspect iron deficiency. Even with a normal hemoglobin, sometimes these changes could occur. The MCV normal range is 80 to 99. Above 90, think of B12 folic acid deficiency. Below 80, think of iron deficiency. But also consider thalassemia and chronic disease if there are clinical features of that. Consider macrocytosis when the MCV is more than 100. And think of megaloblastic anemia when it is more than 110. But in hemolytic anemias also you get macrocytosis. But very often in our setting, the B12 deficiency or folic acid deficiency coexists with iron deficiency, in which case the MCV need not be high. It can be even normal or lower. That depends on which is dominating. The RDW is an extremely useful tool in picking up iron deficiency. More than 14 is abnormal. And in iron deficiency, you get typically high RDW and low MCV. In thalassemia, you get normal RDW, but low MCV, but normal RDW. Because the smaller size are uniformly normal. There is no anisocytosis. All are normal in size. In iron deficiency, there is anisocytosis, different sizes of RBCs. This is what RDW means. One should know what is RDW. It is picked up from the RBC histogram. This is the distribution curve of the RBCs. The size of the RBC is plotted. You get a bell-shaped curve. And if you take one standard deviation on both sides, marked as L1 and L2, and it is calculated by L2 minus L1 by L2 plus L1 into 100, expressed as a percentage, RDWCV. This is more than enough. You don't have to look at RDW, the other one. and above 14 is abnormal. It's the area under the curve. The other RDW is 2 standard deviation, the width of the curve, but it is not needed actually. So coming to laboratory diagnosis of iron deficiency, normal total count, differential count is usually normal, but if it shows eosinophilia, think of a parasitic infestation. Thrombocytosis is often there unless there is coexisting butyl folic acid deficiency. But if there is thrombocytosis, it's typical of iron deficiency. MCV is less than 80, and if it is more than 80 also, if there is coexisting butyl deficiency. RDW more than 14 is suggestive, but if there is doubt, we may get a ferritin value. These investigations are not needed these days. If at all, for research purpose only, even peripheral smear, serum ion, TIBC, bone marrow ion, these are not needed to diagnose iron deficiency, especially these days with an automated hemogram. This was a 15-year-old boy. He became poor in studies, showed abnormal behavior, nail biting, and there was no improvement with the psychiatric medication. And hemogram was like this. Hemoglobin is rather normal, but MCV was low, platelet count was on the higher side, RDW was 16. This is enough to diagnose iron deficiency. And if you carefully look at the nails, it shows flattening. And the nail biting was actually the neuropsychiatric manifestation. So you can easily diagnose iron deficiency by such features. Hemoglobin electrophoresis is suspected when the anemia, microcytic anemia, is refractory to treatment to pick up thalassemia trait, which may show elevated HbA2. And other investigations to pick up the cause of iron deficiency anemia, as I mentioned, like an endoscopy, colonoscopy, all may be done in selected cases. These are only to be mentioned to tell that it's not needed to diagnose or manage patients, can be used as research tools. The percentage saturation or transferrin, red cell protoporphyrin, transferrin receptor assay, these are not to be done. Most of these are not required. This is another hemogram, a 56-year-old tribal patient with alcohol intake, fatigue, abdominal pain, abdominal discomfort, emaciated. She had pallor and stomatitis. Spleen was 4 centimeter. Liver was 2 centimeter. Ferment consistency, mild ascites. Patient had iron deficiency anemia, features of chronic liver disease with hypersplenism. You can see the very high RDW, and you cannot see the how it is here. You can see the total count is 1,400, and hemoglobin is very low, 6 gram only, and hematocrit is 21. MCV is very low, suggesting iron deficiency. RDW is very high, and there is thrombocytosis. This is typical of iron deficiency. But the patient, in addition, had a chronic liver disease with hypersplenism. That is why the total count is on the lower side. So this kind of atypical presentations may be due to other comorbidities. The value of good clinical evaluation has to be mentioned in evaluation of hematological problems, because some doctors at least think that hematological problems can be easily diagnosed from hemogram, bone marrow, and peripheral smear. It is not. This was a patient, a 65-year-old. In fact, he was a doctor who had angina on excision, and TMT was positive. Promptly, a coronary angiogram was done. Luckily, only the coronary arteries did not show critical narrowing, and after that, only the doctor's children, his son and daughter-in-law, everyone was doctor, and they picked up pallor. And at that point, we could demonstrate 2 local blood positivity and colonoscopy, and upper GI endoscopy was normal. Then a colonoscopy showed a carcinoma in the ascending colon, and it was early, easily picked up, and it could be resected, and he lived without any problem for another 15 years, and later on died due to some other disease. In fact, his carcinoma did not kill him. This is another interesting patient of iron deficiency anemia. You can see that 45-year-old male with a progressive pallor and weight loss. He had epigastric pain of 2 months. There was no fever, but the hemogram was like this, 5.6. Total count, differential count were normal, but RDW was high. Platelet count was high, definite iron deficiency. ESR was high, and stool local blood was positive. But upper GI endoscopy was normal. Ultrasound was normal. Peripheral blood and bone marrow also were done because these were done from outside before the patient came to us. And what next? There was no diagnosis, and nothing could be picked up. So, but he continued to have epigastric pain. So we got a CT scan done. It showed a cystic lesion arising from the tail of pancreas, and that was actually a tuberculosis of the pancreas infiltrating into the duodenum, causing chronic GI blood loss. So, in fact, the surgeon also said carcinoma of pancreas, which is inoperable. Luckily, before closing the abdomen, surgeon took a biopsy from the pancreas, and that gave the diagnosis. So sometimes such vague problems can also present with refractory iron deficiency due to chronic blood loss. These are some unusual causes of chronic iron deficiency. Autoimmune hemolysis or mechanical hemolysis or RBCs on prosthetic valve, or even graft, vascular grafts. PNH can be a cause. This patient had PNH with a chronic hemoglobinuria presenting as iron deficiency anemia. Or hereditary hemorrhagic telangiectasia. Always look for telangiectatic spots on the body or in the conjunctiva or in the oral cavity when you have a refractory iron deficiency anemia. There can be chronic blood loss which may not be picked up easily. Now that covers the most important problem of iron deficiency and anemias. Now I'll touch upon beetle deficiency and megaloblastic anemia because they are equally important. Most of the cases are nutritional due to poor intake of beetle and folic acid. Some of them are the so-called pernicious anemia is often autoimmune in etiology, or disease of the gastrointestinal tract, or it could be increased demand of folic acid in pregnancy, infancy, and hemolysis, and sometimes drug-induced folic acid deficiency, like methotrexate use. These are the main causes of beetle deficiency in India. Decreased dietary intake tops the list. Strict vegetarian diet with no green leafy vegetables, because in a vegetarian diet, green leafy vegetables are the only source of B12. That way, many people are not taking regularly. If at all they take, they wash it meticulously. Remember that it is a bacteria, harmless bacteria on the vegetables which give B12 to a vegetarian diet. If they are very meticulous in washing it, they will not get any B12. As such, they do not even take protein enough quantities. Decreased frequency of intake of meat, fish, egg. These are animal products are decreased in people with beetle deficiency in India. Millions of Indians are at risk of beetle deficiency. In fact, almost every other patient is having clinical or subclinical beetle deficiency in India due to several reasons. And these days, extensive use of PPIs and metformin is also contributing to beetle deficiency, which goes undetected. And the autoimmune mechanisms of beetle deficiency are also on the increase because autoimmune diseases in general are increasing. And sometimes it may be atrophic gastritis, which again could be due to beetle deficiency, or gastric bypass surgery, including the bariatric surgery, or total or partial gastrectomy. Zollinger-Ellison syndrome, though rare, gives a mechanism because the increased acid secretion, which is dumped into the duodenum, can inactivate the pancreatic lipase, which is necessary for digestion of the R protein attached to the beetle, which is in the percentage of the diet. So if there is excessive acid production, that can also produce beetle deficiency. Similarly, chronic pancreatitis itself. Very rarely only these congenital disorders are responsible for beetle deficiency. And coming to diagnosis of beetle deficiency, it is always clinical. Laboratory can only help us, provided we have a clinical diagnosis. Traditionally, what was mentioned was peripheral blood, bone marrow, but not needed at all these days. If at all, bone marrow and peripheral blood are done to look for alternative causes like bone marrow infiltrating disorders when the patient does not respond to treatment. B12 levels are useful, but it do not help us because in 50% of them it is normal. It can be even high in autoimmune beetle deficiency. So there is no point relying on beetle levels to diagnose beetle deficiency. You will be missing majority of them. But if it is low, it confirms. But do not rely on beetle levels to diagnose beetle deficiency. If clinical indications are strong, normal values do not rule out beetle deficiency even when the beetle levels are normal. These are some of the clues in hemogram. MCV more than 100 or lower if there is coexisting iron deficiency anemia thalassemia trait. Otherwise, it is usually high. More than 90 itself, you start suspecting it. Hemoglobin can be very low, as low as 4 gram per deciliter. Yesterday, we had one patient who received even transfusion from outside. Actually, the beetle deficiency are missed out because of improper clinical evaluation. Very often, they have leukopenia, but the total count is usually more than 1,500. Platelet count also may be reduced. Sometimes some patients with beetle deficiency are referred for undiagnosed thrombocytopenia. but the counts are never low. It is not less than 40,000. If it is less than 40,000, think of other disorders. Usually it is more than 40,000. And some of them may have pancytopenia. Sometimes these patients with B12 deficiency could have jaundice due to dyserythropoiesis, and that splenomegaly also could be there, which makes people make a totally wrong diagnosis of hemolytic disorder. This is a typical peripheral blood film in B12 deficiency, hypersegmental neutrophils, macrocytes, oilocytes. But again, these are not needed these days because of the if you apply clinical skill properly and look at the hemogram, it is easy to diagnose. These are not needed nowadays to diagnose, and these are rarely found only. Do not depend on these rare findings to diagnose B12 deficiency. Coming to investigations in diagnosed B12 deficiency, if the ESR is very high, think of tuberculosis or an SLE with autoimmune B12 deficiency as the cause for B12 deficiency. And if you think of weight loss and fever, Manto test can help us. Strongly positive Manto can suggest that there is an underlying tuberculosis as the cause for B12 deficiency. Ileocecal junction is an important site for tuberculosis. Thrombocytosis in an anemic patient is against B12 deficiency because with B12 deficiency, thrombocytosis does not usually occur. Cytopenia, normal RDW can favor B12 deficiency when you have suspected it. But if you have suspected B12 deficiency, very high ESR, look for SLE and do an ANA, anti-dsDNA in those cases. The patients with B12 deficiency may present with pancytopenia and bone marrow failure with cellular marrow, very often mistakenly diagnosed as myelodysplastic syndrome. We had one patient who was branded as myelodysplastic syndrome because the genetic studies were positive, but the dietary history alone was not taken, and the patient was wrongly diagnosed as myelodysplastic syndrome. Hemolytic anemia-like presentation I have mentioned because severe iron deficiency can have dyserythropoiesis, and you can get jaundice and mild splenomegaly, and wrong diagnosis of hemolytic anemia is possible with the B12 deficiency. Very often they come with refractory iron deficiency anemia because iron deficiency is remarkable, and you start treatment with iron and supplements, but the patient does not improve because of the coexisting B12 deficiency is not getting corrected. Unless you give B12 deficiency correction, the iron deficiency will not improve. MDS-like presentation is very common because you have pancytopenia, you have cellular marrow. Unless you look for features, you will miss it. Sometimes asymptomatic patients with high MCV can also suggest a subclinical B12 deficiency. Anemia, which is refractory to treatment, is a very common presentation of B12 folic acid deficiency. B12 deficiency always coexists with folic acid deficiency because one cannot work without the other. These are some of the rare presentations which we should be aware of. Loss of taste and smell are not due to COVID, it is due to coexisting B12 folic acid deficiency. And only those people with such deficiencies will have loss of taste and smell, even if they have COVID infection. Defective hearing is a very common presentation. Defective vision, falls and loss of balance may be the presentation. Very rarely they may come with subacute combined degeneration, and which also can coexist with cervical myelopathy or cervical spondylosis. The common disorders always coexist. Premature graying of hair, if it is present, is typical of B12 deficiency, but some of them may have a coppery brown lanugo hair, which also suggests B12 deficiency. Always remember, folic acid deficiency coexists with B12 deficiency in all the patients. These patients with the B12 folic acid deficiency, do not expect them to present with anemia. They may present with neurological manifestation alone, dementia alone, peripheral neuropathy alone, and it can coexist with other cause of peripheral neuropathy, like drug-induced peripheral neuropathy, thiamine deficiency. Reversible melanin pigmentation is a very useful clinical sign. Anorexia is common because of the atrophic gastritis, because the gastric atrophy occurs. And they can have atrophic rhinitis with the foul breath. That is a very common presentation sometimes in some people. Some people can have weight loss, diarrhea due to multiple mechanisms because the mucosal atrophy of B12 deficiency is throughout the mucosa, starting from stomach to the anus, vagina, everywhere. They may come with burning sensation there, or they may have motility disorders like constipation, incontinence of urine, retention of urine. All can be due to coexisting B12 folic acid deficiency, but unfortunately, they are all branded as prostatism. Very often they have these problems as well. Hair loss is a very common manifestation of B12 folic acid deficiency. Unconjugated hyperbilirubinemia because of the dyserythropoietic presentation is common. So in diagnosis of beta deficiency, I have found dietary history as most useful indicator to diagnose beta deficiency. And because symptoms are numerous and vague. Then in the physical examination, knuckle hyperpigmentation, palmar crease pigmentation, and rhombic sign are very useful. And absent angle jerk in some of them can be contributory evidence. And after that, you can, if a patient comes, this young girl who are 15-year-old girl coming with a premature graying of hair, it is almost confirmed that the patient has B12 deficiency. But these patients do not always have anemia. Do not expect anemia to be present along with it. The same patient, you can see the knuckle pigmentation of the hand. This is a beefy red tongue of the B12 deficiency. It appears abnormally red, but there is coexisting glossite cheilitis also indicating coexisting iron deficiency. You can see the knuckle pigmentation again. Always look for it. And sometimes the knuckle pigmentation may not be that obvious. Even this is enough once you suspect B12 deficiency. This another interesting patient, a 36-year-old male, progressive pallor of 2 years, bedridden for 4 months. He was investigated extensively for anemia in different hospitals. He was getting blood transfusion from Tamil Nadu because he belonged to Tamil Nadu. On examination, he had pallor, mild icterus, and typical hyperpigmentation of the hands and hair changes. This was a hemoglobin 6.8. He had a total bilirubin at 4.1, unconjugated bilirubin. TLC, DLC were normal. And these were done from Chennai, which did not pick up the diagnosis. And he was getting transfusion with a diagnosis of MDS. This was one of my first patients with frank B12 deficiency, picked up in 95, 96 or sometime, very long. You can see the premature, he's 36-year-old. You can see the premature graying, knuckle pigmentation, palmar crease pigmentation. Everything improved with B12 folic acid. It was a pure B12 deficiency because he was very rich and he could afford any other diet. These are some of the patients who the vitiligo can suggest that the B12 deficiency, if it is there, is an autoimmune nature. There only you call it as pernicious anemia. This patient with typical B12 deficiency, knuckle pigmentation, look at the flattening of the nails. That gives a clue to coexisting iron deficiency as well. Is serum homocysteine required to diagnose it? Not at all. There's no point doing serum homocysteine because they are non-specific. It could be elevated in several other conditions, and it should not be used for diagnosis of B12 folic acid deficiency. Serum methyl malonic acid is elevated, but you do not need it. If at all, it may be done in a research setting because false positives are seen in 30% and in 15% of elderly. It's not labeled in renal failure. And though it is said that it is useful in early diagnosis, in Indian setup, we should not be doing it because B12 deficiency is extremely common in India. So one should not rely on this. And there are people who even did gastric biopsy to document atrophic gastritis. It is foolishness because gastric atrophy is expected in B12 deficiency. There is no point doing atrophic gastric biopsy in suspected B12 deficiency because it's a phenomenon of B12 deficiency rather than the cause of B12 deficiency very often. But once it develops, it will be a vicious cycle contributing to decreased gastrin, decreased intrinsic factor secretion also. Another interesting patient, 48-year-old female, weight loss, mild jaundice, spleen tip was there, urine showed pustules, pancytopenia was there, hemoglobin 7, total count 3000, platelets was low, MCU was 112, RDW was normal. The bone marrow in this patient was megaloblastic, and you can see that patient had weight loss, and ESR was high. We did that Manto test, it was strongly positive, and the diagnosis was GI tuberculosis. The patient in addition had hypotendelism also, and anemia was multifactorial, B12 deficiency and hypotendelism, and serum cortisol was low. And after treatment with anti-tuberculous treatment and everything improved, even prednisolone could be withdrawn in the patient. So why B12 deficiency in India? People do not practice balanced diet. Lack of empowerment, lack of awareness, food fadism, social issues, cultural issues, and poor absorption of B12, including nowadays the use of PPI and B12, coexisting deficiencies of iron, folic acid, and thyroxine. Hypothyroidism is very common. and that can lead to refractoriness even if you give B12. Strict vegetarians always have B12 deficiency. Non-vegetarians also have, because they are non-vegetarian but they do not consume meat. If at all they consume meat, it may be very, very rarely. Unless they take meat regularly and also get folic acid, they will have features of B12 folic acid deficiency. Autoimmune causes of B12 deficiency are on the increase now. When to suspect hemolytic anemia? Because it is anemia, I thought I'll just touch upon these two more aspects. Hemolytic anemia is suspected whenever there is unexplained severe anemia, rapid fall in hemoglobin without any blood loss, normal urine, acholuric jaundice. Other components are normal, like platelet count and WBC count are normal. Or if you get family history of anemia, jaundice, or splenomegaly, or color-colored urine, or unexplained anemia with splenomegaly and elevated reticulocyte count, one can suspect hemolytic anemia. And the hemogram is otherwise normal, but for the low hemoglobin. Platelet count is usually normal or reduced, if at all, due to folic acid deficiency. MCV is on the higher side due to increased folic acid demand. RDW also is normal, but if there is chronic intravascular hemolysis, you can get a high RDW due to chronic hemoglobinuria. When to consider myelodysplastic syndrome. This is one of the refractory anemias. This is the genuine refractory anemia. The patient has no response to hematinic, including parenteral B12 and proper diet, and but rule out B12 deficiency and autoimmune mechanisms before you call it as MDS. Because some of the patients who are diagnosed as MDS are actually having B12 deficiency or autoimmune causes of myelodysplasia. And if there is organomegaly, it is not myelodysplastic syndrome. Pancytopenia is usually there. Low reticulocyte count is a hallmark of it, and cellular marrow is a hallmark. So if you have a combination of pancytopenia, no organomegaly, low reticulocyte count, cellular marrow, refractory anemia, you can consider myelodysplastic syndrome. So therefore, to conclude, the most useful investigation in anemia is proper diet history. Mixed diet is not enough. A good physical examination, a careful evaluation of the hemogram, and clinical judgment. And list possible causes before asking for other investigations. Like, for example, if you get eosinophilia, it can suggest a parasitic infestation, hookworm infestation. If in a patient with anemia, pancytopenia, lymphocyte count is dominating, it could suggest leukemia because the blasts are counted as lymphocytes. Platelet count high can suggest iron deficiency, low can suggest a B12 deficiency or hypersplenism or bone marrow infiltration. Retic count high only suggests hemolysis. If it is low, think of bone marrow failure syndrome, myelodysplastic syndrome. But the reticulocyte count is high, only do DCT. Very high ESR, look for tuberculosis, myeloma, SLE, MDS, and infected endocarditis. These are useful screening tests because sometimes the vasculitic disorders with albumin global reversals can be picked up. Peripheral blood helps in some patients only. Bone marrow also helps only some patients, not in every patient. These are required sometimes when you want to evaluate the cause for the iron blood loss or TSH. Some patients, when you suspect CKD, you get a urea creatinine, and urine routine sediments might suggest a coexisting renal disease as a cause for anemia. So in general, finally, always multiple problems coexist in any anemic patient. Typically is rare. Every patient is different. Study the patient before studying any investigation. We can interpret the complete blood count or any other investigation only if we study the patient. Even the patient with leukemia could be having coexisting B12, iron, thyroxine deficiency, or chronic liver disease or hemolysis. So multiple causes should be looked for. Individualize a plan when it comes to treatment. Ensure balanced diet, otherwise it will not work. What I have found is people give B12 folic acid iron, they forget to prescribe a diet. Without protein, nothing will work. So prescribe a balanced diet whenever you are treating an anemic patient, and ensure that B12 and folic acid and iron are given when needed. Refractoriness to treatment is often due to overlooking these factors. Blood transfusion is done only in exceptional situations. Never transfuse an iron deficiency or B12 deficiency unless there is an emergency. And the hemogram can be easily interpreted provided we study the patient. And always remember, in hematology, diagnosis will not come from computer printouts. It's a clinical diagnosis. Clinical evaluation and clinical hematology is still the way forward in evaluating patients with all hematological problems, rather than thinking that a peripheral smear and bone marrow will give the diagnosis. Even polycythemic patients are getting peripheral smear and bone marrow these days because of the lack of awareness about evaluation of some of these problems. Thank you for the patient hearing. I can answer questions if you have any. Thank you.
Thank you, sir. On behalf of the audience, I thank you, sir, for a very comprehensive and very interesting talk on anemia with many interesting clinical cases from your vast experience. You have clearly emphasized the paramount role of history and clinical examination in accurate diagnosis. Now, with your kind permission, I allow the audience to come up with any questions or doubts.
No questions?
So your talk was so clear, I think there won't be any questions.
If there are any questions, please don't hesitate to ask. I think I was finished in time.
Yes, sir, exactly on time. Sir.
How many participants were there?
Hello.
How many participants were there?
Hello, sir.
Hello, please.
Sir, I have a doubt, sir. I'm Dr. Rajesh from Thrissur. Actually, in
please.
some cases of pancytopenia, when we are suspecting B12 versus MDS, we often try a trial of vitamin B12 injections. So in such situations, how many doses we should give and see the response to assess whether that B12 trial has failed or not?
Okay. It all depends on if that B12 deficiency is autoimmune in nature. Sometimes B12 deficiency may be autoimmune in nature, and that may be causing MDS-like presentation. Or MDS and B12 deficiency both could be autoimmune in nature. If you are ruled out that only, you can be sure of proper and prompt response to B12 therapy. But if you're sure it is nutritional deficiency, and if you give B12, it will respond within days. Within a week, you will find the response. The patient will say, I'm feeling very well, very much better than before. And you will start seeing retic response and hemoglobin starts improving. But again, that will happen only if other nutritional deficiencies are corrected, including the protein intake, not protein powder. Proper diet with the folic acid supplement should be done whenever you give B12, because B12 will not work without folic acid. So if you have ensured that B12 was given along with proper diet and folic acid supplements and iron also when needed, and if there is no response after 2 weeks, then you can conclude that it is not B12 deficiency. Hello, hope it is clear. Usually they respond within 2-3 weeks. Why I mentioned this point is B12 deficiency is often mistaken as MDS, and this is a common mistake. We had one patient in a major hospital evaluated as MDS because the genetic profiling suggested it was in favor of a MDS, and then he was advised bone marrow transplant. Unfortunately, the people who investigated him did not even look at the dietary history. It was pure B12 deficiency only. So such major mistakes are very common.
Any other questions from the audience? Kiran, Vishnu, go ahead with.
Hello. Please ask.
Hello, sir. Good afternoon, sir.
Please. Good afternoon.
Sir, you said that the anemia with eosinophilia, you would give a course of antihelminthics, and if the eosinophilia is still persisting, how would you proceed, sir?
If eosinophilia sometimes can be a manifestation of autoimmune disorder, like a vasculitic disorder, allergic angiitis and granulomatosis, in which case anemia is multifactorial. Anemia of chronic inflammation also could be there. So we need to find out the cause of eosinophilia in that setting. Nutritional deficiency anemia with eosinophilia will be obvious on the patient profile. The patient will have other nutritional deficiencies. That kind of patient, the patient with eosinophilia of other causes, the clinical profile of the patient will be different. But the patient with eosinophilia of nutritional deficiency belong to another profile. So they will have other nutritional deficiencies as well. Iron deficiency, beta deficiency, folic acid deficiency, vitamin D deficiency, poor dietary habits. So many other nutritional deficiencies may be coexisting in them. And definitely in that setting, eosinophilia means hookworm infestation. And if the patient does not improve after that and eosinophilia is persisting, it could be atopic tendency. And if atopy is ruled out, then we need to look for vasculitic disorders. Sometimes it may be drug-induced eosinophilia. That need to be looked at separately. We need to look for the cause of eosinophilia when it is persisting.
Thank you, sir. Thank you so much.
Thank you. Thank you.
Hello.
Hello, please.
Sir, when should we suspect a PNH in our clinical practice?
Okay. PNH, as such, it is rare. So suspect it only when a patient has unexplained iron deficiency anemia, unexplained hemoglobinuria. That is a situation. Usually it is a person above 30 years, not younger, very young or very old. In the 30, 40 years, in that kind of age group, relatively young person, no other cause. Some of them can present with refractory iron deficiency anemia because of the chronic low-grade intravascular hemolysis with hemoglobinuria. They may present as unexplained iron deficiency anemia, but most of them, at some point of time or other, they will present with cola-colored urine as a history. You will never see a patient without having that history at least once in his presentation. But sometimes they may not come. When they come, it may not be there. Anyway, you suspect in unexplained anemia, especially presenting as iron deficiency anemia, without any organomegaly. Usually there is no splenomegaly. Or if they have thrombotic tendencies. If a patient with iron deficiency anemia has thrombotic tendency, because they very often they can have thrombotic tendencies as well, like deepened thrombosis or Budd-Chiari syndrome. All can occur in patients with PNH. So if you have hemolytic anemia, which is intravascular, and no other cause, autoimmune causes are like typical autoimmune mechanisms are excluded. DCT is negative. But sometimes DCT can be coexisting. False positive DCT could be there. So if you have ANA profile, everything is normal. And finally, you have a subset called PNH. Then you ask for CD55 and 59. And if that is positive, only you confirm it as PNH. Otherwise, still keep the possibility of other cause of anemia.
Okay, thank you.
Thank you. Hello. Hello, please.
Sir, I'm Dr. Ashik. Actually,
please.
I have, sir, only I have some comments, sir, not doubts actually. It was very refreshing for us as if we were sitting in your old clinical classes. We could refresh all those things and we would like to hear more from you. Sir, one more thing I would add, sir, in the earlier query, that is persistent eosinophilia with anemia, could we also consider the possibility of adrenal tuberculosis with
very good. That is a very good point. You should consider the possibility of a coexisting hypotension as the cause for anemia as well, or tuberculosis with hypotension as the cause for anemia. Very good point.
you, sir. Thank you.
Thank you.
Any further questions from the audience? Audience, anybody with any questions? There are no questions, sir. With your permission, may we come to the end of this discussion. I would have requested Dr. M. A. Andrews, sir, to give concluding remarks, but probably he had to join some other meeting. So in case sir is there, I would request Dr. Andrews, sir, to give the concluding remarks. But I think sir had to go for a meeting. So thank you so much, sir, for the very enlightening talk. We would really love to have more talks from you in the subjects of your choice, really, because surely you're a great teacher, and we would like to have similar talks in future, sir.
Definitely, I'm only happy. I'm only happy to be associated.
Yes,
Thank you very much. Thank you for giving me an
asked the
opportunity.
number of participants. We had more than 200 participants, sir.
Okay, very good. That is really good. Thank you. Thank you. Thank you so much.
Sir.
Thank you for that.
Thank you, sir. Thank you so much, sir.
See you again. Thank you.
Yes, sir, we'll definitely. Thank you so much.
Thank you.